नमस्ते बहनों और भाइयों, बड़े ही कम शब्दों में आपको सुनाना चाहता हूँ उस साल का लोकप्रिय गीत ये।
From a retro to the new age, this is the T-Series, yet I'm again, 52 non-stop remix. Yeah. Let's get it on, boys and girls. Are you ready?
मैं डालूं ताल पे भंगड़ा तू भी गिरता पाले चल रंग जमा दे हमके बने सभी मत वाले
हेलो हेलो तू फ्लोर पे टक्कर आई येलो येलो बड़ी सॉलिड मस्ती छाई
हेलो हेलो तू मुझे कुंड लगाई येलो येलो कंट्रोल करो मेरे भाई
बीट है पर कुड़िया देना बहुत स्वीट है
मुझे बड़ा तड़पावे तू देख तो आज भी दिल पर उड़िए तीर संग चल जावे हेलो हेलो दिल से कनेक्ट करना येलो येलो ये बातें डायरेक्ट करना
Hello everyone, my name is Iram and did you enjoy the performance? Was it fun? Yes! Okay, so I have a request. Can everyone put their right hand up please? I know we're eating, I'm so sorry. Right hand up. Can you repeat after me? I promise to dance right now. Let's do this. Come on. We are all Bollywood. I'm from Mumbai and that's where I've been a part of many Bollywood songs as a backup dancer. And I'm here today to make you all dance. I know we're eating. Maybe we can do a little bit of warm-up sitting on our seats. What do we think? Yeah? Yeah, let's go. Let's do it. All right. Yeah. Can I have you put your right hand or any hand up? That's fine. And we are gonna bounce it down. Go ahead. Yeah, let's go. So beautiful. Right ball. Woo! Let's go again. Let's wave. Wow, this looks beautiful. Can we use both hands? Hands on your head. Wow. Okay, let's switch. Y'all are amazing. Roly-poly. Everybody high. How do we feel about standing up for a little bit? Standing up. Can we stand up for just few minutes, just couple of minutes? Come on, let's go. You can just stand up. This is the best room ever. Thank you so much. A big round of applause for you guys. I'm sorry I had to stop you guys in between your food, but now I think we've burned some calories. Yeah. We will see you back again. Thank you.
Wow. I bet you didn't think you were coming here to dance, did you? All right. Welcome. I'm Dr. Shawna Nesbitt, Vice President for Institutional Opportunity, and I'd like to welcome you to our Asia Pacific Islander Heritage Month celebration at UT Southwestern. That was the fantastic ethnic performing group, and they are an internationally recognized dance company dedicated to showcasing the beauty and energy of Indian performing arts on global stages. As for former official Disney performers and featured artists at Universal Studios Hollywood, Ethnic has captivated audiences with powerful, high-energy productions rooted in cultural authenticity. The team are a proud group of World of Dance champions known for their dynamic choreography and strong stage presence. Let's give them a round of applause. And if you didn't get your dance on, stay tuned because they will be back. Yes. We celebrate Heritage Months at UT Southwestern as an expression of a celebration of the various groups of people that make up UT Southwestern, as our staff, our students, our faculty, and our patients and the community that we serve. We are so happy to have all of you here with us today. Just want to thank a couple of our leaders who have joined us. Jeremy Falke over here, our Vice President for Human Resources. And I love the dance. And our AVP for Institutional Equity and Title IX, Travis Gill. And I saw you dance too. Thank you for being here. May 1st to the 31st is the month that the United States celebrates Asian American and Pacific Islander Heritage Month. So we are almost out of the month, but we are still celebrating. This year's theme that was set by the Federal Asian Pacific American Council is Power in Unity, Strengthening Communities Together. The theme celebrates collective influence, storytelling, and bridge-building efforts of the AAPI communities, sharing resiliency, connection, and fostering a shared sense of belonging among Asian Pacific Islander groups in the United States. I think that's a fantastic theme, and it's a great way to segue into the title of our talk and have our esteemed speaker today, who is one of my colleagues from cardiology. Dr. Anand Rohatgi is an esteemed cardiologist, speaker, transformative leader, and a thought-provoking leader in cardiology who has taken on the concept of looking at who we serve and where are the uniquenesses that we serve individuals, and how do we, as an institution, better serve the individuals that we take care of. How do we do that deliberately, thinking about where people come from, how they live, who they are, and what are the differences, and how do we approach that from a health perspective to be very careful to make sure that we bring the health standards of all of our patients to the same level. So I thought it was really important that we talk about the effort that he leads at our Capel facility called the South Asian Heart Health Clinic. Dr. Rohatgi earned his medical degree from Duke University Medical School, completed an internal medicine residency at the University of Pennsylvania, and a cardiology fellowship here at UT Southwestern. He holds a master's degree in clinical science from UT Southwestern, and he's board certified in cardiovascular disease and internal medicine, and he joined our faculty in 2008. In his clinical roles, he is the Associate Program Director for the Cardiology Fellowship and serves on several campus committees to enhance clinical research. He's an active CME speaker and has given many national talks. His research focuses on the role of novel biomarkers in improving risk and prediction for atherosclerosis and coronary heart disease. Specifically, his main interest is in the role of HDL, that is high-density lipoproteins, in cardiovascular disease. He also focuses on high-risk populations, including those with diabetes and people with South Asian ancestry. He's currently the principal investigator of the genetic and molecular basis of cholesterol efflux, a 5-year study sponsored by NIH, and mentoring patient-oriented research in deep lipid phenotyping for cardiovascular disease, funded by NIH as well. He's principal investigator for a 5-year study entitled Lipoprotein Metabolism and Excess Cardiometabolic Risk in South Asians, also funded by NIH, and a separate study funded using the Masala cohort from the US and the UK Biobank cohort in Europe. He has a very long bio, many esteemed presentations, and honored by so many, but I want you to hear from him. I welcome Dr. Rohatgi.
Thank you, Dr. Nesbitt, and thank you to UT Southwestern Asian BRG Group for hosting this event and inviting me to speak. I can honestly say I've never followed quite a performance like that in any professional venue that I've been in before, and I don't know if I'll be able to hold up to those expectations. I will say, honestly, it's a great celebration of culture that we just witnessed, and joy, and being able to connect, and also physical activity and movement. I found it really wonderfully powerful in that way. It also made me flash back to the night before my wedding, because this was culturally aligned with where my ancestral roots, so that was really nice. So I've led the South Asian Heart Program at UT Southwestern for the last 4 years. It's a clinic in our regional clinic at Capel. And I've given talks to UT Southwestern about the epidemiology and biology of risk, especially in South Asians. So for today, I wanted to focus on kind of zooming out and more broadly talking about the epidemiology of cardiovascular disease in all Asian subgroups, and to focus on where there may be similarities and differences, and not only with Asians collectively compared to other groups, but within the Asian subgroup populations. So just start with sort of relevant cases that I've seen in my clinic as a way to think about this. One is a South Asian male, age 44, has a strong family history, has a normal weight, actually, close to normal, BMI of 23 for an Asian, slightly elevated LDL at 135, elevated triglyceride at 220, and a low HDL that signifies risk. And then another patient that I've seen recently, an East Asian female, age 62, her BMI for an Asian actually is normal, but she has high blood pressure, 155/92. And in talking and getting a diet history, has a lot of culturally concordant foods in her diet that are high in sodium. So these are examples of the kinds of patients that we see. And the main theme for the talk really here is that it's been very challenging until recently to really understand cardiovascular risk in Asian populations, because in general, most research studies and health systems have aggregated all Asians into one group. And so what that has done is, in some ways, shed light on the cardiovascular health in Asians, but has masked multiple other observations that limit our ability to take care of people one at a time. So here's a great example of this. So if you focus on the yellow box on the right, if you look at overall death from all cardiovascular disease, and you look at Asians in an aggregated group, they have dropped their mortality from cardiovascular disease. And if you look on the graph on the left, we're at the lowest subgroup compared to many other groups. So one observation from this is that there are low rates of cardiovascular disease in the Asian population. That might translate to less research dollars, less public health resources, less interest and focus on this group, but it masks multiple signals that there actually is very high risk in certain Asian subgroup populations. When we talk today, I'm going to talk mostly by country of origin, is the way that oftentimes these health data are discussed in terms of specific areas of ancestral origins. But there are three categories to think about: East Asian, South Asian, Southeast Asian. So typically East Asian, China, Japan, Korea, and a few other countries really nearby. South Asian are India, Nepal, Pakistan, Bangladesh, a few other countries nearby. And then the countries in the middle, specifically Philippines, Thailand, Cambodia, Vietnam, and some other countries, that would be Southeast Asian. So if you see those terms in my talk, that's kind of what we're discussing, no matter how you may refer to yourself. So if you dismantle the Asian group and you start to look at different countries of origin within Asia, we find actually a different picture. We actually find that South Asian, also called Asian Indians, men have the highest rates of deaths from heart attacks, ischemic heart disease mortality, of all of the Asian groups. And this metric called proportionate mortality ratio, or PMR, says that there is a 33% increased risk of dying from heart attacks in South Asians compared to white reference population. So not the lowest mortality, in fact, the highest. And the same is true for South Asian women. For women, they have the highest rates among all Asian groups and a 33% higher rate of dying from heart attacks compared to the white reference population. So when you start to disaggregate, you actually start to see very different and stark patterns of risk. That's for heart attacks. What about strokes? Strokes are very, very common. They increase with age. They're relevant really for all of us and an important prevention target. Looking at these deaths from stroke, we actually see that all Asian subgroups are at a high risk of dying from strokes, something that you also would not have found with that initial statistic. If you look on the right, that PMR ratio, 1.42 to 1.84, what does that mean? That all Asian subgroups have a 40 to 80% increased risk of dying from stroke compared to white reference population. In addition to that, if you look at the bar graph on the left, among Asian subgroups, there's a twofold variation in dying from stroke, with the Vietnamese population, both men and women, having the highest rates of death from stroke, and the Korean population having a lower rate. Even though they're all higher than a white reference population, there's a gradient of risk. And you can see that this pattern is slightly different than what I just showed you for heart attack risk on the previous slide. When we look at risk factors that translate to risk for heart disease, high blood pressure, hypertension is really, really important. And Dr. Nesbitt is one of our leading international experts on hypertension, so she knows this really well. But if you look on the left, that ratio of dying from the disease, dying from high blood pressure, is increased in multiple Asian subgroups relative to a white population. And if you look on the bar graphs on the right, you can see a twofold variation in dying from heart disease, with, in this case for men, Filipino men having the highest rates and Korean men having the lowest. And the female counterparts have a similar pattern, but not as much variation, certainly less than men, but still increased risk. So what about heart failure? Heart failure is that condition where your heart pump gets either weak or too stiff and the fluid backs up into the lungs and can lead to symptoms like shortness of breath, fatigue, swelling, and cough. Leads to hospitalizations quite often with extensive monitoring and the use of IV medications to get rid of the fluid. It's a very morbid and mortal illness, and it's increasing in the entire population globally, but certainly in certain Asian subgroups. In particular, Filipino, South Asian, and Japanese adults, it's rapidly rising, with South Asians, also called Asian Indians, at the highest rates of dying from heart failure. So if we dig into this epidemiology a little bit more, if you look at the incidence or the development of heart failure, compared to the reference white population, you can see that certain Asian subgroups have even higher incidence of heart failure. And several other groups, Japanese, Chinese, and Korean, are increasing, but you can see the gradient of risk. So there's a lot of variation even among Asian subgroups. If you look at death from heart failure mortality, you can see here the white populations on the top gray bars actually have the highest rates of death from heart failure. The different Asian groups have much less rates of death from heart failure, but still almost a twofold variation among the subgroups. So it kind of depends on what you're looking at, what's important for you from a public health or a clinical standpoint or research standpoint. How you choose to study this depends on what disease you're studying and also what type of population you're investigating. To drill this down a little bit more, because heart failure is so important, if you look at the incidence of heart failure in the East Asian countries, so predominantly China, Japan, and Korea, that incidence is actually lower than if you use a white reference population. The incidence in South Asian countries, so typically India, Pakistan, Nepal, and Bangladesh, have a similar rate of heart failure incidence compared to non-Hispanic whites. And then Southeast Asian, predominantly Filipino population, have actually the highest rates and higher than white adults. And amazingly, in the US, we know that Black Americans have the highest rates of heart failure. It's really a public health epidemic. And interestingly enough, Southeast Asians have the same rates of heart failure as Black Americans. Very, very high rates. So when you start to drill down the disaggregated data, you can be much more precise in your understanding of what's going on and then target the right therapeutic approaches. So the key takeaways from this part is that you have to disaggregate to act. It's not a monolithic category. By collapsing into one Asian group, you mask sometimes over a twofold variation and a suggestion that there's lower rates of death from heart disease when in fact there's more, depending on whether it's heart attack, stroke, or heart failure. And the imperative is really to think about this in not only with individual patients, but at a health system level and a policy level. So those are some of the statistics on heart disease, heart attacks, heart failure, and at least one risk factor that can lead to those conditions, high blood pressure. But another one is adiposity and hyperglycemia. This is a really big deal, not only for all adults, but in particular Asian individuals. So you can see here on the graph, the gray bar is the rate of diabetes based off of a BMI on the x-axis. So the gray bar is for the white population, and you can see here right between 23 and 27, right around 25, you start to see the rate of diabetes go up. But look at the red line. The red line is in the South Asian and the Filipino groups. That rate of diabetes goes up at a much, much lower BMI. And this is one of the challenges at using BMI as cutoffs because it can miss ectopic fat and adiposity, especially in the Asian population. Drilling this down further, this is what's been described as the skinny fat or the thin fat paradox. If you compare Asians to other populations, not only is the body surface area smaller, but the overall amount of adiposity that's reflected by your height and weight is not reflected. There's a lot more absolute fat that's hidden beneath that leaner body surface. So what are we talking about? Visceral fat on that diagram, that's the yellow that wraps around your abdominal organs. Hepatic fat, fat in the liver, fat actually in the muscle, intramuscular fat, and also lower muscle mass. So these are the body composition patterns that are very typical for an Asian individual. But the person and the physician often will miss this because it's literally hidden. But these lead to inflammation, insulin resistance, hyperglycemia, fatty liver, and then a whole host of cardiovascular conditions. So another point to make in terms of why BMI is such a challenge to use, if you look at the top row in yellow, this is and then the first column is the BMI cutoff for obesity. So for white individuals, it's 30, a BMI of 30. But look at the cutoffs that have been designated by the World Health Organization and other entities for obesity, much, much lower for various Asian subgroups. And then the screening threshold for diabetes in the second column is 25, the overweight category for white individuals, but as low as 20 for certain Asian subgroups. By the way, my BMI hovers between, 24.5 to 26, depending on the week and the month. And so for many years, I thought I was normal weight, but in fact, as an Asian man, I am solidly overweight. So here's a fascinating study. Then they looked at, well, what about people who are normal weight? What about the diabetes risk? So for white individuals, that's less than 25. So they looked at white individuals with a BMI of less than 25. And for Asians, it's less than 23. So they only looked at Asians who had a BMI less than 23 and only looked at white individuals with a BMI less than 25, what we would call normal weight for both groups. And the reference is the bottom bar, the white population of the risk of diabetes. Well, all of the other Asian groups had a 4 to 8-fold increased prevalence of diabetes within a normal weight population. So even if you compare normal weight to normal weight that's respectful for those differences by race and ethnicity, there's still a much, much higher risk of diabetes. So there's a lot of work to be done. Now, today's talk is not focused on the data around food and exercise. I've done that in previous settings here. But I want to pay homage to it because of how important it is. Clearly, diet and activity are contributing to this. And we know that there are variations in different cultural cuisines and diets in various Asian countries, from high carbs, high fat, to high sodium loads. In addition to that, the longer we spend time in a diaspora, so the acculturation, we accommodate the practices of where we live. So sometimes that's healthier, usually less smoking. But what's not healthy is more processed food, more saturated fat. And so that compounds the challenges with the current food patterns. And then physical activity and muscle mass end up being really important for Asian populations. At least for South Asians, it's really well known that South Asians have much less physical activity, less steps, more sitting, less standing, less moderate and vigorous intensity exercise, and lower muscle mass. This leads to insulin resistance, leads to diabetes, and then other cardiovascular goals. And if you're wondering, this is how I looked in my 20s. No, I'm just kidding. But there is an opportunity to improve, in particular, muscle mass by resistance training in the Asian populations, which can combat many of these metabolic problems. So we've talked a little bit about the epidemiology of the disparities in this cardiovascular risk across Asian subgroups. And in addition to lifestyle, oftentimes lifestyle is just not enough, and we have to use medications to what I call enhance that portfolio of health so that we get a return that we want in the future. And a lot of these cardiometabolic medications work. They're well proven. We prescribe them a lot. A lot of people, many of you may be on these medications here. But what do we know about their specific effects within the Asian population? So with respect to pharmacogenomics, statins and rosuvastatin in particular has a particular variant that affects the levels of the drug in Asian subgroups. So this is called ABCG2. It's very common in Asian populations, and it leads to higher levels of the drug in many Asian groups. So what does that mean? One, it's the most common in East Asians, more common but not as much in Southeast Asians, and still elevated in South Asians. So we know for sure in East Asians this can be a real issue. And so the guidance on the FDA package insert, so rosuvastatin is one of the most commonly prescribed statins to reduce the risk of heart attack and stroke. It's the one that I prescribe a lot in my clinic. But for a person who is Asian, the FDA package insert says if you're Asian, doesn't disaggregate, it says if you're Asian, start at 5. Because what you don't know is what the effect of that will be on lipid levels, but also potential side effects from the drug. well tolerated, but if the levels are much higher than you expect, maybe there's a higher risk of side effects. So for many of my patients who are Asian, in particular East Asian, we will start with 5 and then test and then potentially go up slowly. Another drug that's very important for cardiovascular risk is the blood thinner called clopidogrel, also called Plavix. This is a blood thinner that's given to patients who receive stents in their heart arteries or have had heart attacks, sometimes strokes, and it thins the blood. And you may have to take this for a year or even longer, depending on what your doctor advises. This variant, called CYP2C19, causes a problem with the effectiveness of the drug. And guess what? Almost 50% of East Asians and 20% of South Asians have this variant. What does that mean? That this drug is less effective if you have the variant. Upwards of 1 in 2 East Asians or 1 in 5 South Asians could have this variant. And of course, as we talked about, many of these individuals are having the heart attacks, the stents, and the strokes, and will likely get on the drug. So there's a risk that the drug won't work as well. The good news is you can do genetic testing for this pretty easily, and you can switch people to blood thinners like ticagrelor or prasugrel that don't have this issue with this variant. So these are 2 examples of very common drugs used for very common conditions, very important, that can have a pharmacogenomic impact within Asian populations. Shifting to more cardiometabolic drugs, SGLT2 inhibitors like empagliflozin, trade name called Jardiance, is often used to treat conditions like diabetes, also used in people with heart failure, and also used with people with kidney dysfunction. Very, very powerful, amazing, almost a miracle drug in terms of what it can do, has changed our entire landscape. What about its effect in Asian individuals who have very high rates of diabetes and heart failure and other metabolic problems? Well, if you look at glycemic control, the effectiveness of this drug class is double compared to the white population. So if you look at trial data and then you disaggregate Asian subgroups, it's actually more effective in lowering blood sugar. What about in people with heart failure? This is one of the 4 pillars of drugs we use in people who have diagnosed heart failure to literally save their lives. The benefit in the white population in all the trials is about an 18% reduction in risk. It's more than double that benefit in Asian populations, over 40% reduction. And then for kidneys, it's the same, it's not reduced. So this drug class, which has been a game changer for protecting people from diabetes and cardiovascular and kidney disease, is more effective in lowering sugar, more effective in protecting people with heart failure, and as effective in people with kidney disease in the Asian groups. Very, very powerful information. And then I'll end with this drug class. This is the drug class everyone is interested in learning more about and interested if they should be on it. I'm also wondering if I should talk to my PCP, since I now know I'm overweight, are the GLP-1s. So the GLP-1s were, again, used to treat diabetes, and now we know they can cause significant weight loss. They shred the fat, the visceral fat around the belly. They reduce inflammation. So for all those reasons, perfect type of drug for all Asian subgroups. And we know that they work. They also have benefits in protecting people from heart disease. So what do we know about the effects of GLP-1s in Asians? So some of the large trials with semaglutide, this is one of the most common GLP-1s that is used in the market, did have substantial cohorts in Asian countries, in particular Japan, South Korea, China, and Thailand. And they saw the same weight loss effects that they saw in the main trials, upwards of 10 to 13% weight loss, which is incredible. We still are shocked that you can do this, but you can. And so the effects on weight and the shredding of visceral fat, as far as we know, is similar in Asian subgroups, in particular people from those countries on these drugs. I looked at all the data, and then I used an infographic to summarize the data on GLP-1s in Asians. So here you're just seeing the summary effects. So if you look at the effect of GLP-1s on protecting people from heart attacks, strokes, heart failure, death, like big important endpoints and outcomes, in the white cohorts in the trials, about a 15% reduction from heart disease events. It's double that in the Asian groups that were studied, 31% relative risk reduction. If you look at something called number needed to treat, this is an easier way to talk to someone about what's the magnitude of effect. So you have to treat about 70 people who are white from the trials to save one heart disease event with this drug. You only need to treat 30 for about half the number of Asians. So it's twice as effective in Asian individuals as it is in other populations. The paradox, even though they are more effective, 40% less likely to get the prescription. So there's a opportunity gap, an implementation gap here that I actually didn't know about until I researched this for this talk, actually. And so this is an opportunity, I think, for all of us to do better. So what are the gaps with the data, especially for GLP-1s? We have good data, actually, because these trials are 10, 20, 30,000 trials. So the subcohorts in Japan, Korea, and Chinese are substantial enough to say, yeah, this works. It might be more effective, if anything else. What we don't know is some of the other Asian subgroups, like South Asian and Filipino, Vietnamese. And we know that all of these subgroups have more visceral adiposity, have more diabetes. What are the effects in these other groups? So there are still some gaps. So if you're interested in your own assessment of risk, what do you need to do? Some of these are the same for everyone, but know your numbers, your blood pressure, your glucose, your lipids, your BMI relative to that Asian-specific cutoff we talked about. Waist circumference is a crude way, but a good way of looking at visceral fat and your family history. Think about asking your physician about some advanced laboratories. So we didn't talk about these today, but think about tests like ApoB, which is the most comprehensive measure of bad cholesterol in your body, a genetic marker called lipoprotein A, and an inflammation marker called CRP. And then I think the field and myself and our preventive groups are moving towards that step 3, where we have all of this metabolic risk, but it's hidden. How do we know? And how do we know that you and you are responding to the same foods in the same way, or that movement is having the same effect? So wearing a continuous glucose monitor can be powerful. Getting a very simple and cheap assessment of body composition, how much fat and muscle you have with something like a DEXA scan, and then sort of more gold standard, state-of-the-art imaging to see if you have any hidden plaque in your arteries. Some of these might be the right thing for you if it helps improve figuring out if you're at risk. So the takeaways from this is that, number one, risk is heterogeneous. The cardiovascular risk in Asians is subgroup specific, and if you aggregate that data, it masks these disparities. Lifestyle is the foundation, paying attention to food, and when it comes to activity, all forms of activity are great, especially like what we just witnessed. Very, very, very good, but also for Asian populations with low muscle mass, resistance training ends up being really, really important. Thinking about when therapies come along to think about is genetics going to be important if I get prescribed a certain drug, and should I be on an SGLT2 inhibitor or GLP-1 because of those enhanced benefits that we see. And then lastly, of course, why you're here probably is that we can all be champions. We can all be champions by promoting this and calling this out when we see aggregated data, really for any group, but we're here today talking about Asian groups, is to say, well, what about? Do we know? Have we checked? How can we learn in the different subgroups? Our clinic in Capel is focused on the South Asian group, and we've been here for about 4 years. I'm partnered with my dietitian, Parul Sharma, who's on faculty here at UT. And we try to do this as best as we can with our patients, is to do these types of assessments and provide tailored culturally concordant care. We also do research, as Dr. Nesbitt nicely introduced. We have research funding looking at these issues in South Asians. We have an ongoing coronary CT angiogram study. We've also done outreach. We do outreach probably every 2 months, and we're hoping to increase that to twice a month if we can, with partners in the community to screen people and raise awareness. If you're interested in anything more relevant to the South Asians, I had the opportunity to co-chair a statement on cardiometabolic health, but not just to review epidemiology. This statement is a framework of how to move forward, how a health system can move forward and implement some of these things. So with that, I'll end, and happy to answer questions or move to the next session. I will say just one thing is that you may ask, well, how do we do at UT Southwestern? If you're a patient and you come in, what did they ask? Well, up until August of 2025, the only category you could pick was Asian at UT Southwestern. It's the West Coast and the East Coast that have disaggregated. but nowhere in the middle of the country, and certainly not in Texas, or at least here in our health system. So we talked to Epic and we said, we need to do more. So we've disaggregated into 3 large groups. And the slide didn't make it here, I apologize for that, but I was just looking, and we have 10 to 15,000 people who have picked one of those 3 categories just since August of 2025. So there's a lot more work to be done. Thank you for your time.
If you have questions, raise your hand. We'll bring you a microphone for questions. While we're waiting, I have a question for you relative to the GLP-1s. Now, do you think the lack of use of GLP-1s in Asian patients is because people are not aware that the BMI is different in Asian populations, and the thought process behind prescribing is more for people who are overweight or who have diabetes? Do you think there's some other, insurance issue? What's your thought?
Yeah, I think that's the driving factor. Because of the way that the trials were done and how insurances cover it for obesity, they haven't changed the thresholds for Asian populations. So many Asians who have a BMI less than 27, less than 30, will not be considered obese from an insurance coverage standpoint, and many providers just won't be aware that they actually are overweight or obese. There's also, I think, a lack of cultural awareness and acceptance of pharmacotherapies to be part of the health journey in a lot of Asian cultures. So I think there's some opportunities there. And what I didn't have time to get to is that GLP-1s reduce everything except for bone, as far as we know. They reduce fat, but they also reduce muscle mass. And we had a great talk this morning at Cardiology Grand Rounds about GLP-1s and muscle mass. And what's unknown is, since Asians are starting out with much lower muscle mass, is there a differential impact on muscle quality in Asians?
Now, for the non-physicians in the group, if you don't know what a GLP-1 is, that would be Wegovy and Mounjaro and Zepbound, and there are a couple new names that are oral drugs on the market as well. Questions? Right here.
So my question was, I know you talked about the BMI being different. Is like blood pressure levels supposed to be different for Asian versus a normal non-Asian?
Boy, you hit the nail on the head. So I would love to answer that question. I haven't seen anything related to that. People are starting to look at all of these other metrics and say, wait a second, what if all these other measures, blood pressure, LDL, triglyceride, HDL, all of these numbers maybe should be on a different scale of threshold. So ourselves and others are investigating that exact question. That's a great question. It's a question I have too. Yeah, great question. The question is if you take a GLP-1, is that lifelong? So if you take it, you will often sustain the weight loss. When people have studied, if you stop it, about 2/3 or more will regain the weight and 1/3 will not. So a lot of prep goes into conditioning yourself before, during the treatment to improve your food intake and activity levels so that if you do decide to come off, that you can maintain the weight loss. It's a little bit unclear, but the vast majority of people will tend to regain their weight if they stop it, if they haven't changed other things about their metabolism or lifestyle.
A little closer to your mouth. Pull a little closer to your mouth. Pull a little closer. Yeah. Okay.
Okay.
There.
So, great talk. Thank you. Very informative. It was very helpful for me. And the question is, there are several reasons to be obese. Some people is because you have diabetes, and other people is by stress. And so, because of these different origins, do you have any comments how to treat them differently? Or, and also, another question was age. So when young people, normally it's by stress, they become obese, right? And the old people, that the muscle are very important for them. So
Yeah, it's a great question in terms of, are there different reasons why people might gain fat or weight, and does that help us? And the answer is absolutely yes. Some people are genetically primed to have more adiposity. Others, the vast majority of us, have less activity, increased calorie intake. That's the majority reason. But how people put this on, you can tell, is different. Women in particular have an additional challenge as they go through their menopausal transition, because that's where a lot of that visceral fat and ectopic fat start to accumulate. So there are a lot of different reasons. So I think individually you do need to work through a particular patient or a person, what has been their life history with weight, but then also what is the metabolic consequence of that body type or body frame. Is their sugar normal or abnormal? Blood pressure, cholesterol. If everything's reading normal, then perhaps the attention isn't as much about weight loss as maintaining and enhancing their overall health and making sure that those numbers don't start to get deranged, versus someone who already has diabetes. That's a major issue and can really help treat the disease. When people get older, there's an issue with too little muscle mass. So you have fat, too much fat, not enough muscle mass, and so it's very complicated to work through a person to make sure that they don't get frail by losing too much weight. Very, very important.
So I have a question so I noticed the Filipino and South Asian risk was higher than those of Korean or Japanese descent. Is it due to the foods that we eat, or is it more of the genetic profile?
Yeah, that's a great question. It's the million-dollar question. And I think the answer is probably yes and yes. I think there are differences in how we eat that contribute. So there's a more enhanced sodium load in East Asian foods, whereas like a South Asian Filipino foods, there's enhanced carbs and saturated fat. So that's a generalization, but there's some stylistic differences in the nutrient composition more broadly. And there's very likely genetic priming over hundreds or thousands of years that have led to some of the differences in how we respond. Because you can see this as if certain groups of people have the same types of food and activity, they may respond very differently metabolically. Some groups, the triglyceride shoots up, others the sugar shoots up, others it doesn't change all that much. I didn't hit on this, but East Asian populations have much higher rates of what we would call small vessel or hemorrhagic stroke, bleeding strokes. And some of that's related to high blood pressure, but some of it's related to how the blood vessels geometrically and architecturally are in the bodies of, in particular, East Asians. So there's some anatomic, biologic differences that might contribute as well.
Hey, Dr. Rohatgi, when you talked earlier about people regaining the weight when they stop the medication, do they regain the weight or regain the visceral fat?
Yeah, great question. Again, we had a great topic this morning on just these questions. It seems like you're regaining the fat and you're not regaining the muscle mass that was lost on the medicine. So there's a real challenge, and usually for me, I'll ask people to do 6 weeks of resistance training before starting, and then continue resistance training, strength training during, so that we can kind of mitigate those kinds of changes. So you regain the fat, you don't regain the muscle as much. Yeah.
Any last questions? I'll ask you one last one. It is true in other groups, African Americans, there's been shown that as people migrate from their country of origin ethnically, that there are clear differences in gradation. African Americans, that's definitely true with blood pressure and the risk of diseases. Do we see the same thing happening for Asian populations, is moving from the culture and environment, to a westernized culture makes a big difference?
Yeah, it's really challenging because there's multiple moving parts. So one is that some health behaviors and lifestyle behaviors actually improve to higher first world countries. Usually you see a drop in smoking. So there's a lot of smoking in many Asian countries, but that tends to drop if they migrate to Australia or the UK or the US or Canada or some other countries like that. But in contrast to that, there's increased sedentary time, less manual labor jobs, more sitting desk jobs, and the ultra-processed food you get from our communities here in the US at least contributes to a lot of worsening. Add to that the differences of being a Texan versus a Californian versus a New Yorker, right? So there's so many nuances. Has this family or this person been here for 40 years or just came last year? Is there extended family? Who's doing the cooking? What's the cultural importance of how they move or don't move, what they eat and what they don't eat? So it gets a little bit hard. There's a lot of moving parts.
Thank you so much. I love that segue.
Thank you.
Because health and culture are at the segue and meet together, and recognizing that how we live and where we live is equally as important as the biology that we all carry, and our genetics determine some piece of that, but all of that other part of how we live and where we live is the soup we live in, and it determines a whole lot. Thank you for joining us today. I am going to get out of the way, and if you didn't get all those calories worked out when we started, we're going to have Ethnique come back and close us out, and you may stay for the dance until you finish, or you may leave us, and we look forward to having you join us for our next event. Thank you.
जी 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 बाजे रे बाजे रे बाजे रे ढोल बाजे इसकी गोल 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 तो ढम ढम बाजे ढोल हाँ हाँ छोरा है नटखट बोली है पटपट अरे छेड़े पूछे बोले ऐसे बोल तो ढम ढम बाजे ढोल ढोल बाजे ढोल बाजे ढोल बाजे ढोल के ढम ढम बाजे ढोल के ढम ढम बाजे ढोल बढ़ के कर्म क्या अब ठोक सके तो ठोक ले दुनिया हम दोनों बेमिसाल सज धज के कमाल बाहें डाले हुए बाहों में जो नाचे ढिंढोरा बाजे रे You color and fracture the light. You can't help but shine. The lights, your face, your eyes, exploding like fireworks in the sky. Chumma 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 ke sitare vargi. Touching on your body while you're pushing on me. Don't you in the party? I can do this all week. We'll be dancing till the morning, go to bed, we won't sleep. Chumma 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 ke sitare vargi. Touching on your body while you're pushing on me. Don't you in the party? I can do this all week. We'll be dancing till the morning, go to bed, we won't sleep. Chumma 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 ke sitare vargi. Lights, your face, your eyes, exploding like fireworks in the sky. और म्यूजिक स्टार्ट करो भाई लेके 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 प्रभु करो और म्यूजिक स्टार्ट करो भाई लेके 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 प्रभु करो नाम नाम नाम
Thank you for coming, and we look forward to seeing you at our next event. We will be celebrating Pride Month, and that is going to be on Saturday, June 6th. So over at North Campus, and you should see registration information coming out about that.
For you too.